It's my pleasure to introduce our first speaker, Dr. Abbara, who is a consultant endocrinologist at Imperial College and an NIHR clinician scientist who's been conducting research in reproductive endocrinology with a special interest in women's health. Ali has published widely in the field of reproductive endocrinology in IVF treatment, PCOS, congenital hypoglycemia, hypothalamic amenorrhea, etc. And today he will be talking about the assessment of menstrual disturbance. Ali, over to you.
Okay, thank you very much, Amir, and good afternoon to everyone, and thank you for the invitation to join you and present. Okay, so let's start with what is a normal menstrual cycle length? So it seems to depend on the guideline that you refer to. So of course, there's going to be some variation in what's considered to be an abnormal menstrual cycle length, but you can see that the vast majority regard a cycle length of less than 35 days as being normal, but you can see the Federation of International Gynecologists will accept up to 38 days. So it used to be that in the olden times, researchers would pay patients for their data. However, now patients pay big technology to take their data from them. So this is data from over 1.5 million women using the Flow app. And we can see that only 16% of women actually have the so-called typical 28-day cycle. Nevertheless, 91% of women in this cohort had a cycle length between 21 and 35 days, with the vast majority having a longer cycle length rather than a shorter cycle length, although they used quite a lower threshold of 21 days. And more than 2/3 of women had variation in their cycle length, so between cycles of less than 6 days. But what determines the total menstrual cycle length? So this is again data from 30,000 women using Clear Blue ovulation detection kit. And we can see that the menstrual cycle length more closely relates to the duration of the follicular phase rather than the luteal phase. So it seems to be the follicular phase is a bigger determinant. And this information is quite useful because it enables us to predict the likeliest day of ovulation according to cycle length. So the darker colours are the ones where it's more frequent according to cycle length. And so this can be quite helpful for identifying the fertile window, which starts from 3 to 5 days before ovulation and can last for a couple of days afterwards. And that can be helpful for aiding in ovulation and conceiving, essentially. But of course, the main reason we're interested in menstrual cycle length is it implies ovulation. So how true is that? Does a regular cycle necessarily imply ovulation? So the ASRM practice guidelines suggest that although an irregular cycle more than 35 suggests chronic anovulation, they would also regard cycle lengths at the upper end of normal, so between 32 to 35, also potentially needing to be assessed for ovulation. And then in another large Norwegian cohort called Hunt, with more than 30,000 women with regular cycles, so less than 36 days, up to a quarter were actually anovulatory. So again, even comparing the anovulatory from the ovulatory cycles, there wasn't a huge impact on the duration of the luteal phase, but it's becoming increasingly recognized that even healthy women with regular menstrual cycles can have sporadic anovulatory cycles. And in particular, women with hyperandrogenism are thought to be more likely to have anovulatory cycles, even if their cycle is regular. So typically as endocrinologists, we tend to confirm ovulation after the fact, so retrospectively with a mid-luteal progesterone. So it's important to remember that progesterone during the luteal phase is a pulsatile hormone. It spikes and follows LH pulses by about 55 minutes. So you can get many-fold differences in progesterone even within an hour or so of measurements. So traditionally, we've used a relatively high threshold of progesterone to indicate ovulation, so typically more than 30 nanomoles per litre. But this study by Laver and colleagues suggested that even a threshold more than 15.9 has very high specificity for detecting ovulation. Likewise, we usually just measure hormones on just a single blood test when we're assessing patients in clinic. So we recently did this piece of work looking at how variable and how representative is a single measure compared to hormones throughout the day. And we can see that LH, not unexpectedly, is the most variable, being a pulsatile hormone, whereas estradiol and FSH are much less variable and could probably be assessed with a single blood test. So what are the other factors that affect cycle length? So cycle length seems to be shortened with increasing age. So this is a graph on the left showing the proportion of women with a long cycle length, so more than 35 days. And we can see that with increasing age, there's less and less women with a long cycle length. So with increasing age, cycle length shortens, but conversely, the proportion of long cycles increases with increasing BMI. But generally, cycle length seems to mirror ovarian reserve, and factors associated with worse ovarian functions, such as increasing age and smoking, are associated with shorter cycle length. And in fact, this has been borne out in this systematic review, which includes more than 11,000 women, where they showed that women with shorter cycle lengths, which they defined as less than 28 days, have lower AMH levels by 9 picomoles per litre than those with regular cycles. They're also less likely to fall pregnant spontaneously and have fewer eggs and lower pregnancy rates after fertility treatment. Additionally, this study of 250,000 women in the UK showed that abnormal menstrual cycle frequency indicates women at greater risk of cardiovascular disease and some other conditions there. So an abnormal cycle length can also identify women at increased risk of health conditions. So cycle length reflects ovarian reserve. And we observed this in our own data from a few years ago, where we showed that anti-Müllerian hormone, AMH, which is a marker of ovarian reserve, was increased with menstrual cycle length. But interestingly, even within cycle lengths that we would consider within the normal reference range, so between 28 and 35 days. Additionally, on the right, we show that the risk of menstrual disturbance, likely due to PCOS in this cohort, was gradually increased according to the level of AMH. In particular, we found that an AMH more than 40 had high specificity for predicting menstrual disturbance due to PCOS. And in fact, women with a full house of PCOS features, often referred to as phenotype A, had even higher AMH than those with only 1 or 2 clinical features of PCOS, suggesting that very high AMH reflects a more clear-cut and potentially definitive diagnosis of PCOS. So AMH looks promising as a marker for PCOS, but what should the threshold be? What AMH level should we be looking for? Well, it very much depends on the AMH assay that's being used in your lab. So the Alexis assay by Roche tends to report lower than the previous Beckman-Coulter Gen 2 assay and the Pico AMH Anchlabs assay. And much like HbA1c's A1C from a few years ago, there isn't yet an international standard for AMH. And even beyond assay differences, there's also a need to perhaps modify the specific threshold in local populations. Nevertheless, the Aphrodite study was conducted in the Netherlands by Joep Laven's team using the Roche Alexis assay to try and define what is the specific AMH threshold to use. So it's a very well conducted study. They had both a development cohort, which included 500 women with PCOS and 500 women with who are healthy controls, and then a second similarly sized validation cohort to confirm the performance of the thresholds identified. So for the primary analysis, they included patients with phenotype A of PCOS, i.e. the full house of PCOS features. And the median AMH was 44 picomoles per litre in women with PCOS, but only 11 in the healthy controls. So a nice separation between the two groups. Of note, the healthy controls happen to be a bit older in this particular study, but BMI and AMH were higher in the women with PCOS. So in this study, they didn't actually aim to identify a threshold for AMH to diagnose the entire condition PCOS per se, but rather they were aiming to detect polycystic ovarian morphology. So for this purpose, the best compromise between sensitivity and specificity was reached at an AMH of 23 picomoles per litre. But of course, as you can see from the graph, as you go to the right of it with higher AMH levels, you can get even higher specificity. And this is the graph from the same study showing the distribution of healthy controls in blue, and in pink, the women with PCOS according to their AMH level along the x-axis. So again, you can see that as the AMH is increased, it's much more likely that that woman will have a diagnosis of PCOS. So as we know, AMH is a marker of ovarian reserve and falls with increasing age. So they then assessed whether age or BMI altered the performance of AMH at this threshold. So in women with PCOS, AMH is maintained higher for longer and then falls more precipitously at menopause. And we can see that although it does fall in both, it is lower in both healthy controls and women with PCOS, actually its diagnostic performance is maintained both in older women and women with overweight or obesity. So as I mentioned, for the primary analysis, they'd selected women with phenotype A, i.e. the full house of features of PCOS. But you can have different combinations of the three key features, so polycystic ovarian morphology, oligomenorrhea, and hyperandrogenism, and they all have slightly different characteristics. So, for example, phenotype D, who do not have hyperandrogenism, tend to have a lower BMI. And so they had a look at AMH levels according to the different phenotypes, so on the left, and you can see that AMH was similar in most of the phenotypes, but it was lower in phenotype B, which is the one where you don't have polycystic ovarian morphology. So they interpreted this to indicate that AMH relates most closely to the presence of polycystic ovarian morphology, and therefore they recommend that it should be used for that indication. So for the moment, the international guidelines for PCOS, recently updated in 2023, do not recommend AMH as a single blood test to diagnose PCOS as a condition, but it can be used as an alternative method to identify polycystic ovarian morphology, and so it can now contribute to the diagnosis of PCOS. So AMH is probably going to be a more convenient option than performing an ultrasound to measure the antral follicle count. It's less invasive, it's more easily available, and it can vary a tiny amount during the cycle. So it drops at ovulation, it's slightly lower in the luteal phase and the follicular phase, but generally this won't affect interpretation too much. So it can be measured at any time in the cycle. And as this nice data from Prof. Scott Nelson in Glasgow shows, it can even be measured whilst on contraceptives, but it might well be about up to 20% lower. So AMH can certainly be useful to differentiate PCOS from healthy controls, but often when we're seeing women in clinic with oligoamenorrhea, the alternate possibility is another condition causing menstrual disturbance rather than healthy control. And so the second commonest cause of menstrual disturbance that causes FHA is functional hypothalamic amenorrhea, or FHA. And this is a condition where essentially there's insufficient energy for fertility. This results in decreased hypothalamic function and suppression of GnRH pulsatility, resulting in amenorrhea. And as this study shows, as energy availability falls to less than 30 kilograms per kilograms of lean body weight mass, there's a reduction in GnRH pulsatility. And that results in decreased LH amplitude and frequency. However, again, that threshold shown by the black line here is not necessarily associated with amenorrhea. So it's not really clear cut. Yes, there's an increased tendency to have an amenorrhea to the left of this line, but there's clearly different personal thresholds for an individual, which may well be genetically determined. So it's useful, also useful to bear in mind in terms of recovery from FHA, women often need to gain a couple of kilograms of body weight more than the body weight at which their periods stopped. So on the face of it, differentiating FHA and PCOS should be straightforward, but it can be challenging, especially in leaner women. So, and that's because these two conditions do have some features in common. So Of course, for a start, one of the features they have in common is they can both present with menstrual disturbance, although FHA typically presents with amenorrhea and PCOS with oligomenorrhea. Secondly, one of the other cardinal features, polycystic ovarian morphology, is common in PCOS, but it's also very common in healthy women, being present in up to 20% of healthy women. So it's not necessarily specific. And importantly, it's more common in women with FHA, so maybe up to 40% of women with FHA. So the presence of PCO morphology ovaries doesn't necessarily indicate PCOS. Hyperandrogenism, if present, is more indicative of PCOS than functional hypothalamic amenorrhea, where typically androgens will be reduced. However, one of the phenotypes, so PCOS phenotype D, does not include hyperandrogenism. So this study had a look at what sort of features can help differentiate phenotype D PCOS from FHA. And one of the things they identified was the LH to FSH ratio, which reflects increased GnRH pulsatility, was most differentiating in that situation. And we've summarized some of the key features that could help differentiate these two conditions in this review from 2021. So as I said, one of the key ways that these two conditions differ is in terms of GnRH pulsatility, which is increased in PCOS, there's an increased pulse frequency, but it's reduced in women with FHA. And just highlighting some future perspectives based on our research. So we've been looking at the use of a hormone called Kisspeptin. So Kisspeptin acts in the hypothalamus to stimulate hypothalamic GnRH secretion. And so we're investigating whether we can use Kisspeptin as a diagnostic test of hypothalamic function in women with reproductive disorders. And so in particular, looking at women with menstrual disturbance, I won't go, this is still some work in progress, I won't go through it in detail, but essentially it does appear that we can use the response to Kisspeptin to differentiate women with FHA in gold from those with PCOS in red. And another rare condition that can mimic FHA, especially in terms of biochemistry, is congenital hypergonadotropic hypogonadism, or CHH, and that in combination with anosmia is the condition Kalman syndrome as one of the examples. So patients with CHH, here shown with blue, do not respond to Kisspeptin, whereas those with FHA, here shown in gold, if anything, have an exaggerated response to Kisspeptin. So again, a Kisspeptin test could be useful in this scenario when assessing women, for example, with primary amenorrhea, where these two conditions could present very similarly. Finally, the differentiation between FHA and PCOS is predominantly a big problem in leaner women, so typically women less than a BMI of 24, 25. PCOS is the commonest cause of menstrual disturbance, but at least half of these women will have an increase in their BMI. So women with increased BMI who present with menstrual disturbance will often almost inevitably receive a diagnosis of PCOS. However, we did wonder whether, some of the characteristic features of PCOS, like a very raised LH and raised AMH level, if anything, tend to be reduced in women with obesity. So we did put this review together to consider, is there a condition in women that has secondary hypogonadism that's related to obesity, which could be analogous to MOSH, which is male obesity-related secondary hypogonadism, maybe a FOSH, if you will, a female secondary hypogonadism that's due to obesity that may be separate from PCOS. So you can read more about some of those mechanisms in this paper. Okay, so thank you for listening. I hope you found that interesting. So probably the main take-home message is to be more nuanced. And although there's obviously going to be benefits to having really clear diagnostic thresholds, you can make a clear diagnosis, we do need to take these labels with a pinch of salt. So, for example, a woman with a 37-day cycle has irregular cycles if you're an endocrinologist, but might be a normal regular cycle if you're a gynecologist from the FIGO International Federation. And the truth is probably even people with normal cycles, some of them will be anovulatory, and it's probably more of a continuum than we'd like to think. So we should probably try and move away from absolutist binary thinking, and there's probably going to be gradations of what we would consider normal, even within the normal range. And perhaps in future, there'll be even more focus on individualized assessments, so certainly with technology and various things in place of these rather broad labels. Okay, thank you very much for your attention.
Can you go back to your slide from clinical endocrinology? You had a very useful slide that looked at both FHA and PCOS and how you differentiate between the two, because I think the audience might want to have a look. It was a very useful summary of the two. This one, excellent.
Okay. So polycystic ovarian morphology can happen in both. BMI is obviously a higher BMI is going to point you more towards PCOS, but the BMI in FHA can be up to very normal ranges. So you can be up to a BMI of say 24, and even sometimes even higher BMIs if someone has very, very low body fat. So androgens will probably, if you have high androgens, that's going to point you more towards PCOS, whereas conversely low androgens or normal low androgens to FHA. And LH level, so increased LH pulse frequency will point more towards PCOS, whereas reduction more towards FHA. The vast majority of women with PCOS will have insulin resistance, so high insulin levels, especially on an oral glucose tolerance test. So endometrial thickness. So in the past, people did used to do what's called a progesterone withdrawal test. So essentially, you give people a course of progesterone, and you see if they then have a withdrawal bleed after that. So essentially, what that assesses is estrogen exposure in the preceding weeks, and really what it tells you is about that specifically. So it doesn't necessarily tell you the diagnosis. So it's often been used in the literature as this tells you whether it's PCOS or HA. It very much tells you whether what amount of estrogen they have been exposed to. And endometrial thickness will give you the very similar information. So the low endometrial thickness, they're unlikely to have a withdrawal bleed, and higher, they're more likely to have a withdrawal bleed. SHBG is often lower in PCOS, and as we mentioned, AMH can be higher in FHA than healthy individuals, but it's even higher in women with PCOS.
Thank you very much, Ali. Some quick questions. I'm looking at both the Q&A and the chat. So does GnRH test help in the diagnosis of FHA?
So we are assessing that as part of the study that I showed you in terms of Kisspeptin. So we will give you some new data. I think the previous data is generally GnRH responsiveness is preserved. We did publish a study using a GnRH agonist fairly recently where we showed that the FSH response is reduced in women with PCOS. But generally, yeah, we wouldn't recommend a GnRH test.
And any role for clomiphene in the management of FHA?
So it can be. So I think we say that FHA is a low estradiol state, but the Endocrine Society guidelines actually accept a estradiol level of about 150, which you'll often see in the follicular phase. And I think the new SFE guidelines even accept up to 200. So it's possible that women will have a response to clomiphene, but obviously because of the way it works is to antagonize estrogen. If estrogen's already low, it means they're less likely to respond. So it's possible, but it's a lower sort of option.
And there's a question about high LH in PCOS. So you said it's because of increased GnRH pulsatility. I presume the question is why do we know why there is increased pulsatility?
So there's a lot of debate in the literature as to does PCOS start in the brain or does it start in the ovaries and then affect the brain? So There is some data where they knocked out androgen receptors from both areas, and they showed it's only when they knocked it out in the brain that you get the onset of the PCOS. So suggesting that it's the brain that's important. When you have, so it's thought to be a primary reason. When you have high androgens, that acts in the hypothalamus and blocks negative feedback from sex steroids like progesterone. And so that's thought to be what causes the uncontrolled increased GnRH pulse frequency.
Thank you. And you mentioned about the AMH is both a marker of ovarian reserve and marker of PCOS. How can you interpret the ovarian reserve in a female with PCOS using AMH?
So, I mean, they're linked. So women with PCOS tend to have high AMH and high ovarian reserve. So when they undergo fertility treatment, which is probably the primary utility of AMH at the moment, they're more likely to have lots of follicles develop in response to stimulation, and they have a higher risk of ovarian hyperstimulation syndrome. So they're associated things, and that's why women with PCOS tend to have a slightly later menopause, for example. So they have higher ovarian reserve.
Thank you. And there's a question about the role of androstenedione in differentiating PCOS and hypothalamic.
Yeah, so generally they recommend using testosterone for the majority. There are a portion of women where the androstenedione does seem to be raised. So if the testosterone isn't raised and there isn't clinical hyperandrogenism, then the androstenedione is an option. And I think in our own data, it actually works probably better than testosterone. The differentiation between the two is higher, but generally they recommend testosterone as the sort of first line thing to look at.
And DHEA in PCOS?
DHEA again. So I think went to a talk the other day by Prof. Alt, and she suggests she measures all of them, but it's not in the guidelines yet.
5-alpha reductase activity, does that have any utility in differentiating?
Not in clinical practice. I think there was a study where they showed that might be increased in women with PCOS. So I think they gave them a bolus of androgens and looked at how much is converted to DHT, and there did seem to be a difference, but it's not something that anyone would do in clinical practice just yet. But yeah, that's interesting.
Thank you. And there's a question about naltrexone and FHA. Do you have any experience?
Again, it's not, so naltrexone is a sort of opioid antagonist. So high opioid tones is one of the things that's thought to contribute to the decreased GnRH pulse frequency that you see in FHA. And there have been studies where it can increase GnRH pulsatility. Again, it's not something that I've seen used in clinical practice ever, but yeah, it's again interesting. So the Kisspeptin neurons in the hypothalamus express dynorphin, which acts on those opioid receptors. So yeah, there's a theoretical reason why you can't use it in some data, but not huge amounts.
I was going to talk about PCOS as a multi-systemic syndrome in need of a holistic overview. Bassell, over to you. Thank you.
Thank you very much, Professor Sam, for involving me today, and always a pleasure to speak to. I can tell from the questions we're receiving, very lively cohort, and always a pleasure to follow Ali as we work together and do quite a lot of research jointly, and usually our nights out always end up with so much debate on PCOS, so between gynecology and endocrinology. So I'll try to avoid the political traps. So today what I wanted to sort of focus more is on the recent updates from the international PCOS guideline, specifically focus on initial assessment and evaluation, taking a holistic overview. Unfortunately, we would not have time to cover management. I do not have any conflict of interest. These are the sort of the outline of the talk and what we will be covering overall. So PCOS is, I'm sure everyone in the audience would know, is the most common benign endocrine condition affecting women of reproductive age. It's absolutely very common, yet routinely underappreciated, misdiagnosed, and mismanaged, and it contributes to significant health burden on society. Now, syndrome, it has varied features and often varied phenotype. So you would definitely expect some reproductive element of the PCOS, that is namely irregular menstrual cycles, infertility, and higher predisposition for endometrial cancer and pregnancy complication. There is also a metabolic element with higher insulin resistance, metabolic syndrome, and conversion to or like higher prevalence of type 2 diabetes. Cardiovascular risk factors, so they have higher rate of chronic hypertension, cardiovascular disease, and also hypertensive disorders in the pregnancy and sleep apnea. Often, while we use it for the diagnosis, the clinical hyperandrogenism and the methodological element of PCOS is not very well managed, and a lot of the women we see will actually be left to manage it on their own without proper involvement of dermatology as a discipline. And finally, and that's always the sort of missed child of these symptoms, is the psychological element is very, very poorly screened for and evaluated, and PCOS leads to significantly worse mental health, body image, and sexual dysfunction. So I'm hoping to be covering how to screen and evaluate all these elements in a very comprehensive and holistic approach. Starting with the diagnosis and screening. Now, the knowledge about PCOS has evolved significantly since it was a Steen-Leventhal syndrome. And I'm sure probably everyone in the audience will know that we currently use what is called the Rotterdam criteria, which has evolved to an AE-PCOS Society criteria. The very first criteria was the NIH, which took only hyperandrogenism and menstrual irregularity, and with time they incorporated the polycystic ovarian morphology. Now, what is hot off the press is when this is from the last AE-PCOS Society meeting, is that there is a big drive to change the name of the syndrome and convert it to something on the line of polymetabolic syndrome, and that is acknowledging that it's not really just about the cystic appearance of the ovary on the ultrasound, specifically that these are not cysts but rather follicles that have arrested in their development. So watch the press. There will be a change in the name. We're still not sure how that will benefit the progress in the condition, hopefully in a positive way. But critically is, how do we go about the diagnosis, and do we always need an ultrasound, which is what Ali has alluded in his previous talk, is that we might not need ultrasound scan in all cases. So the current proposal from the guideline is that the starting point is always, are there irregular cycles, and is there clinical hyperandrogenism? And then do you measure biochemical hyperandrogenism? And I will expand on this a little bit. Again, we touched upon what blood test to ask for, and this remains a heatedly debated area. There's no clear consensus on it. And then if you have only irregular cycle, or one of them, or hyperandrogenism, then you can proceed to do the ultrasound. Now, what is often missed, and I see a lot coming from primary care, is that there is a need to exclude other causes. Now, we gynecologists are guilty because we don't really venture into excluding these. Well, confident that the endocrine colleagues are more confident and capable to explore congenital adrenal hyperplasia and Cushing syndrome and acromegaly and other causes that could be contributed to similar symptoms. So doing a comprehensive sort of blood test and physical assessment is important to follow this algorithm. Now, there is also an ongoing debate about, do we over or underdiagnose PCOS? And it's important to incorporate the patient voices in exploring this, because a lot of women would say, I really want to get diagnosed so that I know how to proceed with it. While on the flip side, you see in the literature a lot of debate, again, between gynecology and endocrinology, as in like how exclusive these diagnostic criteria that we're using, whether the NIH or the Rotterdam are, and how specific they are in differentiating what is PCOS and what are other causes. So that yield the importance of really conducting a comprehensive assessment and going down the differential diagnosis before just simply labeling it PCOS based on the appearance of some follicles on the scan. So let's consider this case study, which is something we'd see in the clinic every day. Cheryl is 17-year-old. She's been referred by her GP. She has no periods for the last 6 months. She's doesn't really care about having periods, but and thinks that it's better that she doesn't have them. They can be embarrassing. And she's been recently experiencing more acne, and they're causing her social embarrassment. There is also an element of being withdrawn and less interested in school activity. Her BMI is 26. So if you are in the clinic and you're seeing Cheryl probably come in with her mom, what would be on your mind? What would be your differential diagnosis, and what sort of test you'd like to arrange to explore this further? Currently, the guideline is differentiating from menarche, 1 year to 3 years, and post years, how many days is the length of the period, or how long the periods have been absent. So it's important to consult this current sort of flow diagram. But the critical bit is that diagnosis of PCOS in adolescent years is really tricky, and there is still no clear guidance about how to go about it. So important is to consider that they are at higher risk of being labeled or diagnosed with PCOS later on in adulthood. I mean, 70-year-old probably is verging on adulthood. And it's important to reassess the risk and reassess the clinical progress. Traditionally, you would probably manage such cohort with a low estrogen tablets, combined contraceptive pills to give them period for the interim. But as the audience have suggested, important to consider other elements such as their physical activity, their weight, and try to optimize their diet and so on. Again, I'm not going to dig too much into the management. Irregular cycles are again hard to assess, and as Ali alluded, nowadays there is more apps that everyone is using. And while they are useful, I don't think they are being used in clinical practice efficiently. And I recommend all my patients to follow and track their periods on the Flow or Clo app. I don't have any financial links to them, not promoting them, but it's always useful to consider a more robust sort of menstrual diary when you are in the clinic and trying to come up with a accurate assessment. Now, an interesting sort of byproduct of this is endometrial hyperplasia. And again, Ali touched a bit about the importance of appearance of the endometrium on the ultrasound. So in my clinic, all the fellows who are scanning, they're not allowed to just say thick endometrium. That means absolutely nothing. They need to measure it. They need to comment, is it late follicular phase? Is it early follicular phase? Is it ovulatory? Is it secretory? How is it appearing? And because we are a fertility clinic, we also assess the endometrial blood flow into the endometrium. The critical element is that women with PCOS have higher risk of developing hyperplasia. Interestingly, there's still no consensus where does hyperplasia fit. Is it a normal, benign menstrual disorder? Is it a precancerous disorder? And I think that has contributed to a very limited sort of guidance and evidence synthesis on the condition. But for the interest of today's talk is that if there is no period and there's consistently thickened endometrium that is appearing heterogeneous and with an endometrial thickness above 7 millimeters, then that warrants at least a biopsy and then further investigations. I don't think there is a higher tendency nowadays to do outpatient hysteroscopy. I don't think this is warranted. In most of the available meta-analysis suggest that a diagnosis of hyperplasia is quite sufficient and reliable with just a simple pill biopsy that is done in an outpatient setting. And the treatment is clearly to restore the cyclicity of women with PCOS, and we tell every woman you should have at least 4 periods a year with the withdrawal bleed, if not on a continuous contraceptive pill. The other element is hyperandrogenism and hyperandrogenemia. And again, this is quite a characteristic feature of PCOS. Again, we briefly touched upon what is the best marker. Is it androstenedione? Is it DHEA? Is it free testosterone? Is it total testosterone? Is it FHA? I think the sort of knowledge about this is still evolving. However, the current guideline is suggesting that FAE has the best diagnostic accuracy, and this is the test to go for. You can consider doing total testosterone and the other test that we discussed, and that is to rather complement the assessment and rule out other conditions, as you guys have mentioned in the chat. The key message that I wanted to highlight is that there is still no clear consensus about what is an abnormal testosterone value, and this tends to vary between lab to lab, and it is a lot of variations depending on the assay that your lab is using, and also what are the normal thresholds. Currently, there's still most of these studies are reporting it on 5th and 95th centile. And the guideline has clearly alluded that these need to be linked more to clinical outcomes. So it's important to, when you in your clinical setting, to really ask your lab how they're diagnosing or what are the normal threshold in testosterone and how these were agreed upon. I don't know why I'm having, sorry. And another element that is often missed, and again, I think gynecologists are more to blame about, is other features of hyperandrogenism, namely alopecia. It could, most of the women coming to my clinic, they never been asked about this question, and they would often dismiss it, so they don't really think of much of it unless you go about and ask for it and probe for it. And it's important to describe it and can do a proper assessment of clinical hyperandrogenism using Freeman-Galloway score. I don't know if any of you guys have used it in paper. I still find the images are a bit, laughable because they're from like the 90s and they haven't really developed. But I recently found a tool that is AI-based and give you far better sort of examples of how the different hyperandrogenism status would be. And I think it will help the women to really self-assess themselves. And there is more and more evidence that self-assessment of FG score is actually fairly reliable and doesn't need to happen in the clinic. So we tend to give the women a questionnaire that they can do it themselves, again, with the Ludwig score for the alopecia, so that we can mention that at least to the GP. And even, within our PCOS clinic, we try to come up with a proper assessment of the clinical hyperandrogenism. Now, ultrasound appearance, again, this is quite hotly debated in that what is FHA, like you discussed, and what is PCOS. Traditionally, the drive was to label a PCOS where you have the pearl necklace appearance, where there's a peripheral distribution of the follicles that are arrested in their development, while you have a more thickened stroma, as you can see in the top picture, while at the bottom picture, this is what you would call multicystic ovary rather than a polycystic ovary. So this tends to be associated more with HFEA. These are not very exclusive and not very specific signs, but it's important to comment as such in the ultrasound scan. And again, in our clinic, we try very hard to really assess PCOS and not label anyone with eight or more follicles as PCOM or polycystic ovarian morphology on ultrasound. The current guideline is quite specific on which marker to use, which is FMPO, follicle number per ovary, FMPS, follicle number per section, and total ovarian volume. The meta-analysis available tells that the most accurate by far is the FMPO, where you need more than 20 follicles per the whole ovary. So you're measuring the ovary in 3 diameters and trying to capture these. There are now more and more AI model that are counting the follicles. So we use them more in IVF and follicular tracking, but they're quite useful in PCOS context, but they have not been validated. So these are emerging, and I'm hoping they will help to stratify the diagnosis and ultrasound reporting better. It's important to consider that this is more on transvaginal ultrasound because it's a bit superior compared to transabdominal to measure FMPO. And again, the guideline is suggestive that if you're doing transabdominal ultrasound, let's say in someone who's Virgo intacta, then a total ovarian volume is a much more useful marker. And obviously, you're looking for ovarian volume more than 10. And as I mentioned to you, it's important to standardize this ultrasound scan process in your clinic. If you ask if the ultrasound is performed by a generic sonographer, they probably will not be looking for PCOS per se, or the reproductive assessment in as a whole. So it's important to have this SOP where you standardize in how the ultrasound is being done, capturing all these features that I have on the screen. So when was the LMP? What is the accuracy or the bandwidth or frequency of the transducer use? Again, there's higher accuracy with higher with specific probes and the transvaginal element. What are the numbers of the follicles? And as I mentioned, important is the endometrial thickness and the pattern, the appearance, and its relation. Is it out of sync with the menstrual with the menstrual period where it is, and is it out of sync with what the ovary is showing? Again, we touched upon AMH, and as Ali alluded, that AMH is suggested as a replacement for ultrasound. And I saw in the chat that a lot of people were asking, how do you do that when you're considering fertility treatment for women with PCOS? And the answer is that AMH performs well in the middle, but on the extremes, it doesn't really do very well. So if someone has an AMH of 66 compared to someone with an AMH of 90, for example, that's more test variation. And there's also concerns about the assays that are being used across different labs in terms of the reproducibility of the AMH results. So there's still some mileage to be done before AMH is really reliable test. I agree it should be specifically be called a marker of ovarian reserve rather than a diagnostic test for PCOS. Now, my personal reservation is if you look at the meta-analyses looking for the threshold for diagnostic accuracy for AMH in the context of PCOS, they tend to range between 5 to 15. And I think we can all agree that a normal responder woman coming for fertility treatment will probably have an AMH of 10 or above. And it's important to take this into context of age as well. So, you know, it's hard to see how it is a very accurately diagnostic test, but it can be helpful in contexts where you do not have access to ultrasound. So it can, you know, if you have ultrasound, I think at this stage is still a better marker to measure. And the important element also to consider is that AMH is influenced by several factors. So I spoke about age. BMI is a very important one. It tends to have lower AMH with BMI. And clearly, if someone was on the pill, so you'll have a lower AMH value as well. So all these are important elements when you are interpreting the AMH. I'm trying to answer that question in a fertility setting. So moving on to another case. So Aisha is a 36-year-old factory worker. She's been referred by GP with concerns of excessive weight gain. She works the night shift. She often snacks on junk food. And she has a daughter who is 15-year-old, was conceived normally. Her periods are irregular, the mom, not the daughter. And they've been absent for 6 months. And she feels tired. Her daughter says that she snores at night. And her most recent HbA1c was 46. I'm sorry, I know it's a dense case history, but I wanted to challenge the audience as I know you're all excellent endocrinologists. So my question is, clearly she probably has PCOS. I think we can all agree about that. But if you're seeing her in your clinic, what are the health risk factors on the long term that you'd be telling Amanda to, you know, she's at risk at, and what sort of further test you'd like to arrange for her? Again, I'm going to stop for a minute if we can get the comments from the audience. I'll stop sharing so I can see them. Oh, I love salivary cortisol. I'm not sure any gynecologist will be doing that, but thank you for the idea. Agreed, type 2 diabetes, hyperlipidemia, hypothyroidism, completely agree. Or I say yes. Great. Completely agree. I think pretty much we have consistent answers so far. So if I take the slides further. So you all alluded to the risk of, let's call it metabolic syndrome and higher insulin resistance and diabetes. And there is, you know, a substantial body of evidence by now that women with PCOS are at higher risk of type 2 diabetes and insulin resistance, irrespective of their BMI. So it's very important to have a longitudinal assessment of this. And again, in the NHS, very few women come to my clinic as to the gynecology with any assessment of their diabetic status. So if you can't arrange an OGTT, which is the gold standard for evaluation of this glycemia, let's call it, in women with PCOS, at least arrange for a HbA1c. The difference is that the threshold of what is IGT and what is type 2 diabetes are not very well established in HbA1c versus the OGTT, and there's still quite a lot of debate about it. I'm not going to venture into that. It's slightly outside my area of expertise. I'll leave it to the endocrinologist, but the key element to mention is that everyone with PCOS, they need at least a yearly HbA1c assessment, and more frequent can be evaluated depending on their BMI and other risk factor for type 2 diabetes. Now, something that is often missed is when they do get pregnant, they are obviously at higher risk of GDM, gestational diabetes. While the current national guideline in the UK recommends that they have it at 24 to 28 weeks, we often would recommend that they have them a bit earlier, so at 16 weeks, because they might actually be having what nowadays is more acknowledged as a cold type 2 diabetes that is emerging in the first stage of pregnancy. Cardiovascular disease, and again, so there's no straight link in terms of causality between PCOS and actual worse outcome. There's higher association between PCOS and cardiovascular risk factors. And what's important to bear in mind is that you know, you need to perform a full comprehensive assessment of their cardiovascular risk and on the long term. So in my clinic, we use Q-risk, and we try to share that with the GP so that they have that information and try to factor it into their long-term care for the patient. And obviously that leads into the management, which we're not covering today. The first line will be lifestyle intervention, in addition to other elements such as managing dyslipidemia and so on. Obstructive sleep apnea is largely ignored. It is a very important factor to not ignore in PCOS, and it's not easy to assess because in the clinic you can simply screen for it by asking, do you snore or do you feel tired during the day and feel lethargic and feel like you need to nap? And the question is often, what do you do once you suspected it? So there are standardized questionnaires, so that they call Brennan's questionnaires that you can use, and we tend to send them before the appointment because otherwise it's very tricky to screen for it in one single appointment. But if you are worried about it, then the formal diagnosis should be done in a sleep study or in a sleep lab, and then onward management should be with a sleep physician. Final case today, and just trying to keep it interesting. So Samantha is 34-year-old banker, and she's been coming to consider conception to the fertility clinic. She knows she has PCOS, and she just recently started to try for a baby. Her periods are regular, but they are irregular in duration. She often bleeds for 2 days and have very heavy periods. She does have clinical hyperandrogenism. She has lost some weight following Mediterranean diet, but her BMI is 32. She's worried that her ovarian reserve is reducing, and she's asking whether she can proceed with IVF. So the question is, would you offer Amanda IVF immediately? And do you think it's a good idea? And what are the risk factors for her if she is to get pregnant? So again, I'm going to stop and ask for your comments. You have been a very interactive crowd. Thank you very much. So as some of you alluded in the chat, the very first intervention would be to assess her husband for potential infertility causes. I love when a lot of people come to the clinic with a day 21 progesterone done when they're PCOS and they're not having regular cycles. I don't know what's the point of that. If they're not having regular cycles, they're not ovulating. a somewhat useless test. So, and the first probably the first approach is to offer her a planned withdrawal bleed and then proceed with letrozole as the first line treatment. But again, I'm not going to go too much into it. A lot of clinic would expose them unnecessarily to what we call hypoxia, tubal patency testing. The guideline is suggesting that they do not need it, and you can safely proceed with 3 cycles of OI before such test is considered, as long as they don't have other causes of concern, such as a history of STD or previous surgery. As I touched upon already, in pregnancy, they have a lot of risks. So miscarriage, gestational diabetes, higher gestational weight gain, hypertension, small for gestation age, preterm delivery, and cesarean section. So not to scare them, but it's important to counsel them and to introduce screening tests throughout the antenatal pathway to evaluate these. Critically, the OGTT that happens postpartumly to explore their risk of type 2 diabetes, and strongly encourage breastfeeding, and also perhaps take a metformin afterwards, that there is good evidence that it reduces the risk of conversion to type 2 diabetes. Finally, I wanted to cover mental health. So as I touched upon, is that PCOS has a significant impact on overall quality of life. And there is a higher prevalence of depression and anxiety in adults and adolescents with PCOS. Now, in addition to that, there is also higher prevalence of psychosexual dysfunction, and that is very linked to poor body image. Again, very seldom this is explored in any clinical context, whether gynecology, endocrinology, or GP. Very few. We do a lot of a charity work with PCOS charity in the UK, and this is the #1 complaint from patients. And we recently published a survey asking patients what are their frustration with accessing care in the NHS, and the #1 was that no one is really exploring the mental health element of PCOS, and no one is offering help. And so the Australian guideline in its previous version that led to the international guideline previously suggested these very simple questions to screen for depression and anxiety. So it's probably difficult for us as maybe endocrinologists, gynecologists, to assess and evaluate and diagnose depression or anxiety, but at least we can screen for them in these very simple questions. And I'll leave a link to the Australian guideline. It's hard to find, but you can find it. And similarly, as I touched upon, there is a body health, body image problem where most of women with PCOS feel like they're not adequate and that they're trapped in their body and they're not receiving enough support to manage it. And there is also higher prevalence of eating disorders, whether it's anorexia or bulimia and so on, and binge eating, which feeds all into this vicious cycle of insulin resistance and weight gain and poor body image and what have you. So it's important to diagnose these. And again, the Australian guideline has these as very helpful screening questions. They're quite easy to introduce in terms of just probing about them, and we try to include them in our questionnaires. And if the message is that if you have diagnosed them, it's important to make onward referral to a psychologist or a psychiatrist who can help the patient address these issues. Finally, it's very important to work on knowledge and self-management in the community. So give your patients resources and help them to find a peer support online. So Jane Hills have fantastic resources for women with PCOS that are very patient-friendly, and same for the Verity charity and PCOS Relief in the UK. And very quick mention on the importance of adopting this life course approach to a diagnosis of PCOS. So the challenges of PCOS and the health implications and ramification of it will change throughout the life course of a woman. And it's important to not just do a snapshot assessment and follow the same plan. So this needs to be continuously reevaluated. Clearly, the challenge will be, how do you do that in a fragmented healthcare? I don't know. I hope you can reflect on your own healthcare setting in the NHS. We know that care for PCOS is fragmented across the gynecologist, endocrinologist, GP, dermatologist, fertility specialist, and what have you. And so the drive is to establish a multidisciplinary integrated PCOS specific clinic that can remove the barriers to access care and facilitate patients getting diagnosed, assessed, and accessing the treatment they desire. Thank you very much for listening. Sorry if I rambled a little bit extra, and I'll welcome any questions.